Lymphatic filariasis causes most of the lymphedema in the world, but it can also be a congenital lymphatic disorder, podoconiosis, secondary to cancer treatment, or any other disruption to normal lymph flow. Regardless of the cause, lymphedema happens because lymph flow is reduced or interrupted for a long time, not because of an acute event that heals and recovers. So lymphedema is generally irreversible. However, it can always be improved, and if we can intervene early enough, it can also be reversed. Secondary infections can be prevented and mobility can be maintained. Best practice therapy is delivered in 2 phases, with an intensive reduction phase to reverse as many tissue changes as possible and a maintenance phase to prevent progression. The reduction phase should be repeated every year or so, and it's important to note that the same core elements of management are applied in both phases. So if the reduction phase is unavailable, the maintenance phase should still be applied. The exact therapy required is dependent on some fixed factors, in particular the stage and presentation of the lymphedema. This is not a one-size-fits-all therapy, and best practice changes according to the progression of the tissue pathologies. There are other challenges and opportunities which must also be considered in the context in which the intervention is being implemented. And because there is no one-size-fits-all treatment, we need a multimodal approach, which poses additional challenges in low and middle income settings, but I think also presents some opportunities to draw on local resources and traditional practices. One of the questions Linda asked me to address is, why isn't self-care practiced? And the obvious answer here is a lack of significant funding. But the real cause is a historical view that lymphedema is incurable and untreatable and you can't really do much about it. So it gets a very low clinical priority. And underlying this is a lack of scientific investigation, which fortunately has started to accelerate in recent decades. So we're learning a lot. But getting that new knowledge into remote villages still has multiple challenges, and it wasn't hard to make a list of just some. Another big factor is patient expectation, and unfortunately for the more advanced cases, it's unlikely that they're ever going to make an obvious reduction in limb size. So we need to have more ongoing reinforcements and supports in place because everyone's going to suffer self-care fatigue. But if there are support systems routinely available within the community, then they can be encouraged to re-engage with the program. However, we can't even begin to address patient perceptions until we have a hard look at our own. While there is a perception at the planning and program level that people can't do certain things or that it's too hard to implement them, then we are denying the people who have to live every day with this disease the opportunity to adopt the most effective practice that they can. And the first thing we need to do is increase our own understanding of lymphedema and its treatment. The videos in this section are from one of our virtual Training of Trainers lecture series. And I don't have time to give you the in-depth version, but the main concepts are that every cell in your body is living in this nice warm watery bath where the blood vessels are like the tap, always bringing in some nutrient-rich fluid, and the lymph system is like the drain, removing anything harmful. And this constant one-way flow through the connective tissue bath maintains the ideal environment for the health of all cells. But the lymph system is not a passive drain. It's actively pumping the fluid along, and this creates a suction effect that essentially vacuum cleans the connective tissues and keeps the bath water low. And this constant lymphatic pumping is also responsible for creating all our fine body contours. Tendons and veins which stand out from the skin are evidence that your lymph system is working. And also one of the first things that are lost when the system starts to fail. Lymph flow is also crucial to the proper functioning of the immune system, particularly in barrier defenses. And 80% of all the lymph vessels in your body are located just a few millimeters under the skin. where they can immediately remove any invader that has managed to cross the barrier and transport them to the lymph nodes, which house the lymphoid tissue and mediate immune responses. The lymph vessels are arranged in long chains of these pumping lymphangions, which pass the lymph through multiple lymph nodes before the cleaned and filtered lymph is returned to the venous circulation just above the heart. When lymphatic clearance is inhibited, a high protein edema forms in the subcutaneous compartment. Symptoms may be felt before any swelling is visible, but once clinically manifest, this early fluid-rich stage will return a deep, rounded pit on pressure. From here on, all further tissue pathologies are caused by the presence of this high protein edema and degrading proteins trapped in the tissues. Over time, the fluid is replaced by fat and fibrous tissue growth. The lymph vessels themselves are also affected and over time become fibrous and cease pumping altogether. These late changes in connective tissue architecture are almost impossible to reverse. And I cannot emphasize enough how important it is to include people with very mild disease in any intervention, as we have the potential here to reverse all their symptoms so that they won't need lifelong lymphedema care. The pathogenesis of skin and connective tissue changes in lymphedema is reasonably linear regardless of cause. The notable exception is podoconiosis, where the exposure is distal rather than proximal to the edema. So we may need a slightly different approach in the early stages between these two causes. However, once lymphedema is allowed to progress, then the connective tissue changes will become similar regardless of the cause. And the three main treatment outcomes that we'll try to achieve will apply in all cases. Firstly, we want to turn down the tap and stop too much fluid coming into the tissue bath. And we can do this by managing comorbidities, especially ones that can cause venous hypertension, and by reducing the bacterial and fungal load on the skin. We also need to clear the drain and support the lymph system to recover as much function as possible. If skin and tissue changes have occurred, then we want to reverse some of these if we can. To achieve these outcomes, the core elements of therapy are applied differently depending on which tissue pathologies are present. I'm not going to talk very much about skincare and hygiene because this is essential at all stages and the one thing that is being routinely implemented already. But we've got a long way to go before we're offering people the opportunity to adopt more comprehensive self-care, which will include lymphatic exercises to support lymph flow, manual therapies to support lymphatic recovery, and compression therapies to reverse skin and connective tissue pathology. In early lymphedema, walking is one of the best exercises to activate the proximal skeletal muscle pumps, which support lymph flow and maintain mobility. Light pressure lymphatic effleurage also supports lymphatic function and provides the best opportunity for the system to recover completely. Light compression therapy will also reduce the tissue load and increase the chance of complete lymphatic recovery. Once lymphedema has progressed to the middle stages, all hope of complete recovery is gone, and the main aim of treatment will be to prevent further progression. Lymphatic exercises to support lymph flow and clear the proximal parts of the system should be performed several times during the day. Skin and tissue mobilization are used to soften fibrotic tissue, and lymphatic massage is used to support lymph flow. If emollients are used during the manual therapies, this also helps in preventing further skin pathology. If compression therapy can be applied, then a good reduction in limb size should also be possible. In the advanced stages of lymphedema, lymphatic exercise should still be performed, even if walking is no longer possible. The manual therapies can make a big improvement in skin integrity here, but compression therapy is about the only thing that is going to reduce limb size. Elevation is also routinely prescribed in lymphedema, but it's important to understand that this doesn't assist the lymph system. Elevating the affected body part above the heart assists venous resorption of free fluids. So elevation is really only useful overnight when the limb can be elevated above the heart and in the early stages when there is still free fluid to be resorbed. As lymphedema progresses, there is little free fluid present, and so elevation becomes ineffective. Linda also asked me to address what is needed to facilitate lymphedema reduction. When we decide before we even start that we can't teach people full therapy, we set ourselves up for failure in terms of lymphedema reduction. So we need to find new ways to educate patients, caregivers, and health workers in comprehensive lymphedema management. Sustainability will be a key feature of success, and this means that knowledge needs to be held locally so that an individual program can be tailored according to the stage and presentation of the lymphedema. Patients and their caregivers must be empowered to make their own self-care choices based on their individual circumstances so that they can maximize the benefits that can be achieved from the efforts that they expend in daily lymphedema care. Linda also asked me to talk about my experiences in virtual training, and you've been seeing some of my amateur attempts at virtual training tools, which we were forced to make in a hurry so that we could continue to roll out the enhanced self-care protocol in Malawi, Nepal, and Timor-Leste when COVID prevented face-to-face training. Although the CNTD work is essentially finished, apart from some further follow-up in Malawi, we've formed a not-for-profit in Australia to continue the work with the Bangladesh and Ethiopia partners. And we're currently redeveloping the demonstration videos using professional animators in each country. I'd also like to point out that while we called our original program Enhanced Care, it's still not comprehensive lymphedema care as we didn't use any compression therapies. We also only included moderate and severe cases because of the study design. But it's really important to note that filariasis and podoconiosis give us a unique opportunity to actually reverse lymphedema in the early stages. Once the exposure has been removed, if we can apply an intensive period of comprehensive therapy, then their lymphatic system should be able to completely recover full function. And my final comment is that human beings are capable of finding creative ways to overcome obstacles and achieve complex tasks. And this is no less true for people affected by lymphedema than in any other context.